I will begin by first reading the student attestation, presenting my passport, photo, and name for proof of identification as Ruby Williams. Student attestation. All Aspen University students are required to abide by Aspen University's academic integrity policy, as outlined in the university catalog. The academic integrity policy is built upon the concepts of honesty, truth, fairness, respect, and responsibility. By taking this exam, I agree to abide by both the academic integrity policy and the rules outlined on this exam. With this recording, I am attesting that I have personally completed the comprehensive exam and that the information I submit is true and accurate to the best of my knowledge. Ruby Williams, and here is my ID. There's my photo. And my name. Now let's begin. Today, I am presenting on the topic problem-based research plan on integrated trauma care for female veterans. This is near to my heart as a woman veteran and as a survivor of military sexual assault. I also have complex post-traumatic stress disorder, or CPTSD. CPTSD results from chronic, repetitive traumatic events in a person's life. The American Psychiatric Association publishes the Diagnostic and Statistical Manual, or the DSM, and the World Health Organization, WHO, publishes the International Disease Classification, ICD. Both these primary mental health diagnostic systems struggle to recognize complex PTSD as a separate disorder. PTSD symptoms vary between the two systems, with complex PTSD requiring additional symptoms related to emotional regulation and self-worth. Action research proposal outline. I will begin with the introduction, move on to literature review, method, look, think, act, cycle, results, conclusions, and my references. This method is an iterative process of the look, think, act cycle by Stringer and Aragon, 2021. Introduction. The context, background information that created the problem statement, research questions, the relationship between the independent and dependent variables, and what I plan to examine in my research, summary description of the intervention and research method. Women veterans are the fastest growing group of people who need care from Veterans Health Care, but VHA systems have always been made for men. Adjust my camera. My apologies. Okay. Now, a little bit better. Problem statement. About 26% of female veterans tested positive for military sexual trauma. Traditional evidence-based teachings, CPT and PE, which would be exposure, for MST PTSD have a high dropout rate, over 40%, which leaves a significant gap in care. In fully adjusting models, a positive MST screen was associated with an elevated risk of mental and physical health conditions, excluding cancer-related conditions, with odds varying from 9% higher for rheumatic disease to 5.4 times higher for PTSD. Research questions asked: will the incorporation of art and yoga therapy into current military sexual trauma therapeutic approaches result in quantifiable enhancement of PTSD symptom management in women veterans? Will the participatory action research approach improve treatment, engagement, and retention among female MST survivors? What is the effect of a participatory implementation of an integrated art and yoga therapy intervention on PTSD symptoms and treatment? engagement among females, MST survivors in the Dallas-Fort Worth, Texas community. Literature review. Conducting a literature review is essential for understanding the existing research on a concept, identifying methodological issues, and situating new studies within the broader academic discourse. It helps avoid redundancy, uncover new research avenues, and facilitates engagement with ongoing scholarly discussions. The literature review analyzes existing research by comparing viewpoints, identifying a consensus and dissent, highlighting gaps, suggesting areas for further study, and discussing trends, methodologies, and debates while evaluating strengths and weaknesses. The proposed intervention is substantiated by interdisciplinary literature that critiques conventional trauma treatments, highlighting the necessity for embodied and expressive modalities due to the significant attrition rates exceeding 40% of evidence-based treatments, such as cognitive processing therapy, particularly among military sexual trauma survivors. The healthcare system offers specific obstacles that exacerbate female veterans' engagement in treatment. Alternative therapies are needed to increase female veterans' participation. Relevant literature research shows that art therapy works on neurobiological level by providing a way for people to express themselves, helping them integrate their emotions and feel less stressed. Studies that look at stroke patients show that creative art therapy can make depression, anxiety, and stress a lot better. This capacity to address comorbid symptoms and stimulate engagement renders this art therapy an efficacious adjunctive method for complex PTSD. It is an essential way for people who have been through trauma to deal with it without talking about it. It is especially true for people who have trouble expressing themselves verbally, which can be triggering. It facilitates the externalization of complex emotions, helping individuals process feelings of shame and guilt related to the military sexual trauma. Research perspective utilized. The participatory action research. The research adheres to first, second, and third person values-based ethics, emphasizing personal resonance, mutual regard, and social responsibility. This commitment guarantees that the research process is restorative and empowering rather than exploitative. The PAR, or participatory action research, views the community, female veterans, as experts, shifting the power dynamic inherently in traditional research. The process necessitates that the researcher be answerable to two constituencies: the academic community or scholarly rigor, and the participant community for social change. This culturally responsive methodology for MST involves co-designing and continually evaluating interventions with the affected population to ensure relevance and acceptability. And these are my scholarly sources. Method, look, think, act cycle. As you can see, it is a cyclical cycle, meaning that it moves from the planning, the acting, the observing, the reflecting, and then based on those reflections, moving back through the cycle again. Research procedures will be discussed, data sources, data collection procedures, independent variables manipulated, and data analysis. Who are these stakeholders? Women veterans, government funders, clinical providers, Dallas-Fort Worth VA psychologists, local political leaders, art and yoga specialists and trained in trauma-informed care, veteran services, coordinators, and Operation Red Wings Foundation. The core researchers team ensures collaboration and sustainability. Women veterans, 15 to 30 participants from the DFW area as co-researchers and evaluators of the therapeutic interventions. VHA clinical leaders, women veteran program managers, and military sexual trauma coordinators, providing institutional alignment and referral pathways. Government funders, representatives from the Texas Veteran Commission, or TVC, and Texas Health and Human Services Commission. Clinical and service providers, licensed art, yoga therapists, and psychotherapists from local providers, such as Recovery Resource Council and Zoomies Against Sexual Assault. Community partners are VWEC leadership, venue, and logistical sources support, such as using Operation Red Wings Foundation. Qualitative data, administering structured questionnaires to a large sample of respondents to gather data on consumer demographics, preferences, and intentions regarding the new product, which would be the art and yoga therapy. Data sources, there would be independent and dependent variables manipulated. Independent variables include integrated intervention, and this will be a 9-month to 12-month trauma-informed art therapy and yoga therapy. The participatory action research delivery model provides for stakeholder co-design and logistical barrier removal. Dependent variables include measured outcomes of PCL-5, which is the PTSD self-screening of symptom severity, attendance and retention percentages at the program's end. The data collection procedures, photo voice interviews, observations, open-end surveys, thematic art portrayals, closed-end surveys, questionnaires, veteran PTSD, pre and post scores, attendance records, retention logs, and Likert scale scores on symptoms experienced. Data analysis will be the look, think, act, cyclical, iterative process, and thematic art analysis. The look phase gathers baseline PTSD scores and needs assessment interviews with stakeholders, identify primary barriers, lack of child care, and perceived institutional stigma of VHA sites, gather data for collaborative co-design solutions. The think phase, or the collaborative design, stakeholders interpret look data, modifications, secure funding for child care and transportation if needed. Establish sites at a non-clinical VSO, veteran service organization. There's a large stigma with going to veteran facilities for this therapy. Transparency is maintained through co-ownership, fostering trust. In the act phase, independent variables, weekly trauma-informed yoga and weekly art therapy, community settings with supportive services, attendance and retention logs, as I've mentioned, and the analysis of the art and photo voice are conducted. Photo voice testimonials showcase personal testimonials regarding art portrayed. Here are some examples. In the first, I created a forest fire that began with a friendly barbecue. And this is the explanation from a survivor. And as you can see, there's a depiction of a forest fire that started with just going to a friendly barbecue. And that's what led to her assault. Second person, I wore a mask of perfection while drowning in my pain. And as you can see, the lady here is looking off into the sunset, but if you look behind her, there's this shower of waterfall coming down, indicating the drowning of her pain. Next person, I struggle to take the next breath and getting through the day. And as you can see, she's showing how immensely painful this struggle is on a daily basis. And here is this person says, I survived the war, but I came home with battle scars. Interviews, art interpretation, nonverbal data logs, thematic analysis revealed 3 interconnected themes that explain the success of the intervention. Somatic control and safety. Yoga helped participants manage hyperarousal and chronic insomnia, with field notes showing increased stable eye contact and relaxed postures. Guilt-free expression. Art therapy helped MST patients process deep emotional content. Veterans employing the photo voice approach frequently acknowledge their work as a way to externalize pain without judgment, reducing re-traumatization. Quantitative data. We're using descriptive statistical techniques such as regression analysis, correlation analysis, and hypothesis testing to identify relationships between dependent and independent variables and test hypotheses related to the descriptive analysis finding. Summary of the quantitative data. The PCL5 and retention, a paired sample t-test revealed a statistically significant decrease in mean PTSD symptom severity, with PCL5 scores declining by an average of 19 points from pre to post intervention. This change surpassed the benchmark for clinically significant enhancement. The most significant finding was the 92% treatment retention rate, where 25 participants completed. This high rate clearly demonstrates that the PAR delivery model effectively reduced the access barriers that typically lead to high attrition in institutional settings. Analysis for the research proposal presentation encompasses a comprehensive examination of the PCL5, insights from women veterans, group therapists, community therapy, community dynamics, financial funding, location considerations, and strategic retention recommendations. Here's the proposed timeline: 9 to 12 months. So January to March is the look phase. In weeks 1 and 2, recruit research participants for qualitative interviews and focus groups, art therapy and yoga therapy. Weeks 3 and 4, finalize research proposal outline and objectives. April to June is the think, active, and act phase. As you can remember, this is a cyclical phase. So although you begin with the look phase, you kind of are going between the think and act and back and forth as needed based on the data. Week 1 and 2, conduct literature review on relevant theories and concepts. Develop research methodology and instrumentation, qualitative and quantitative. Week 3 and 4, obtain ethical approval and permissions for data collection. And art therapy, photo voice, and yoga therapy will begin. In July to September, act phase. Weeks 1 and 2, continued art therapy, photo voice interviews, and yoga therapy. Weeks 3 and 4, conduct qualitative data collection on the findings. October through December, weeks 1 to 2, transcribe and analyze qualitative data. Identify any emerging themes. Weeks 3 and 4, design and administer second quantitative surveys and complete the PCL5 self-recorded symptomology surveys again. Quantitative surveys report findings to co-researchers, removing any private details identified with women veterans, making recommendations for protocol changes. The results. The study highlights the effectiveness of art therapy in alleviating stress and enhancing psychological well-being among women veterans, supported by both quantitative and qualitative data from methods like photo voice and YouTube storytelling. This mixed methods approach confirms the intervention's efficacy and informs subsequent action research cycles, including policy suggestions for the incorporation of creative arts therapies into veteran affairs programs. The pilot program included 15 to 30 female veterans, which focused on key outcomes such as PTSD symptom reduction and improvements in social functioning, while maintaining transparency through the monthly data review meetings with stakeholders to ensure collaborative adjustment and strengthen partnerships during the scaling. The successful pilot program integrates regional funding and service structures, securing funding and non-VA locations from the Texas Veterans Commission Fund for Veterans Assistance and community organizations, such as amplifying the voices of servicewomen and women's veterans, the Center for Women Veterans, Operation Red Wings Foundation, and Zoomies Against Sexual Assault, which are all women veteran created. The participatory nature of the research fosters a veteran-led infrastructure with graduates trained as peer service coordinators. This approach institutionalizes the intervention as a community resource rather than a temporary grant project. In conclusion, female veterans' multifaceted traumas require a multimodal approach that promotes participation, embodiment, and accessibility. Recent clinical evidence has shown that art and yoga therapy can improve patient outcomes in high attrition settings, and this was done at a VA center in Cleveland. The initiative's strategic success depends on using the PAR paradigm to engage stakeholders from VA leadership to local VSO activists as co-researchers with the veterans in the Look, Think, Act cycle. This ensures the program's local relevance and easy incorporation into the complicated DFW veteran ecosystem. Data transparency and shared ownership of the implementation approach foster a buy-in by all stakeholders. And there is a strong recommendation for a second cycle. The project is about to start a second action research cycle. This one will focus on adding a successful community-based protocol to DFW veteran healthcare and possibly across VHA systems worldwide. The clinical benefit of integrated trauma therapies align with existing literature, showing significant reductions in PCL-5 scores, which supports the effectiveness of art therapy and yoga therapy for trauma processing and somatic regulation. The program achieved a 92% retention rate, significantly higher than typical attrition rates in VHA evidence-based therapies. The success is attributed to the participatory action research methodology, which emphasized collaborative efforts to eliminate access barriers while maintaining the program's context, highlighting the importance of delivery system integrity. This concludes my presentation. Here are my references. There were many, as much was needed to be done. More references, even more references, and final references noted. That concludes my presentation. I am Ruby Williams, Aspen University. My instructor is Dr. Nicole McLaughlin. Thank you.